Good afternoon, good evening, or good morning, depending on when and from where you're joining us. I'm Dr. John Iskander. It's my pleasure to welcome you to CDC Public Health Grand Rounds for May 2019. We have an exciting session, so let's get started. Public Health Grand Rounds has continuing education available for physicians, nurses, pharmacists, veterinarians, health educators, and others. We've awarded more than 11,000 CE credits over the years. The course code is PHGR10. Please see our website or the CDC Continuing Education website for more details. Grand Rounds is available on the web and all your favorite social media sites. Please send questions to grandrounds@cdc.gov, and we'll try to include your question during our Q&A part of today's session. Want to know more? We have a featured video segment on YouTube and our website called Beyond the Data, which is posted after the session. This month's segment features my interview with Dr. Gamage from the Veterans Health Administration. We've also partnered with the CDC Public Health Library to feature scientific articles about this session. The full listing is available at cdc.gov/scienceclips. It takes a village to put on a Public Health Grand Rounds. In addition to our outstanding speakers, I'd like to acknowledge the important contributions of all of the individuals and groups listed here. Thank you. If you'd like to learn more about the origin story of Legionnaires' disease, or LD, as you will sometimes hear it referred to today, check out the CDC We Were There series from August 2016, featuring several of the original scientists and investigators, in addition to today's CDC speakers. Here's a preview of next month's Grand Rounds topic. Please join us live or on the web at your convenience. Starting in June, the physical location of Grand Round sessions will move to CDC's Chambly campus. However, our websites and viewing options will remain the same. It's now my pleasure to introduce CDC's Deputy Director for Infectious Diseases, Dr. Jay Butler.
Thank you, and good afternoon, everybody. I was really pleased to see your slide about the We Were There series, and I really encourage people to go back. If you haven't seen that presentation, do so. And I think it actually is worth starting the time today with a little time travel back to 1976. It was the bicentennial year. Everything, including my high school graduation tassel, was red, white, and blue. Elton John and ABBA were top of the charts. It was also a time when public health was on high pandemic alert, following the death of a soldier in Fort Dix, New Jersey, the prior winter, of a unique and feared to be emerging strain of influenza that became known as swine flu. So in that context of heightened alertness to pneumonia and influenza, several severe illnesses and deaths were identified among primarily middle-aged and older persons in Pennsylvania initially. And influenza was quickly ruled out, but it was found that all of these people had in common having attended the American Legion Convention in Philadelphia at the end of July of that year. CDC's disease detectives conducted an intensive and prolonged field investigation together with investigators from the state and local health departments of what quickly became known as Legionnaires' disease, given the link to the convention. And all of this set the stage to the ultimate discovery of the causative organisms, Legionella pneumophila, by CDC's Dr. Joe McDade, who you may have noticed at the lower right-hand corner of one of the preceding slides, in December of 1976. Legionnaires' disease is a prototypical infectious disease of technological advancement, an emerging infectious disease. What a lot of people don't realize is, in a sense, also a zoonotic disease. In nature, Legionella live and reproduce intracellularly in free-living aquatic protozoa. These protozoan hosts provide a great opportunity to reproduce, but unfortunately for us, that suitable intracellular environment is a lot like that of our alveolar macrophages, and monocytes, providing the opportunity for human infection, particularly in the aged and the immune compromised. So how did Legionella make that jump, or how did they make that jump from their natural protozoan intracellular aquatic environment into the lungs of people? And why did Legionnaire's disease emerge as a common cause of community-acquired pneumonia and also point source outbreaks in the community and in hospitals during the 20th century? The answer may be multifactorial, but I want to call out two particular factors. They were the increased prevalence of two practices. First of all, water that was generally maintained at warm temperatures at which the organism can thrive. So think in terms of what feels good, whether it be a hot shower, a whirlpool spa. That type of temperature allows Legionella to grow to very high concentrations. The second requirement is a mechanism to aerosolize the water droplets containing the bacterium so that they can be breathed deeply into the lungs and infect macrophages and other cells in the human lungs. Thus, Legionnaire's disease is a disease of the built environment. The good news is this provides us opportunities to turn the tide on this life-threatening infection through engineering designs and water management practices, which we look forward to hearing more about today. Thank you.
Our first speaker is Dr. Laura Cooley.
Good afternoon. So as Dr. Butler just mentioned, Legionnaire's disease was first described following an outbreak of pneumonia of unknown etiology at the 58th Annual American Legion Convention in Philadelphia in 1976. In that outbreak, 221 cases were identified, with 34 deaths. Legionella causes severe pneumonia that nearly always requires hospitalization among reported cases. Overall, it is deadly for approximately 1 in 10 people who get it, but is even more deadly in certain settings. 1 in 4 people who get it from a healthcare facility will die of their disease, likely due to increased susceptibility of this population. Legionnaire's disease places substantial burden on the healthcare system, with estimated inpatient costs of more than $433 million per year. Among outbreaks associated with drinking water reported to CDC during 2013 and 14, more than half of these outbreaks and all of the deaths associated with these outbreaks were caused by Legionnaire's disease. To get us oriented, I wanted to start with some background information about Legionella and its relationship to the environment. Legionella, a gram-negative bacterium, lives in fresh water, but in the natural environment, there are insufficient quantities to cause disease. In large, complex, human-made water systems, Legionella can amplify or increase in number to quantities large enough to cause disease, depending upon the conditions. Factors associated with amplification include warm temperatures between 77 and 108 degrees Fahrenheit, stagnation, scale and sediment, biofilm, protozoa, and the absence of disinfectant. Common settings for outbreaks include buildings with complex water systems, such as hotels and hospitals. Even cruise ships can be associated with cases and outbreaks of Legionnaire's disease. To cause disease after Legionella amplifies, it must then be aerosolized or spread through the air in small droplets of water via some device, like a shower head, cooling tower, hot tub, or decorative fountain. It must then be transmitted to a susceptible host, typically people who are 50 years or older, smokers, and people with weakened immune systems or chronic disease. Legionnaire's disease is usually acquired by inhaling droplets of water containing Legionella into the lungs. Less commonly, disease occurs by aspirating Legionella-containing water or by water going down the wrong pipe. Cases of Legionnaire's disease have been reportable to CDC since 1976. The rate of reported cases increased 6-fold from 2000 to 2018. While diagnosis and rates of reporting have improved, these numbers likely underestimate the true burden due to possible underutilization of Legionella-specific tests and thus underdiagnosis of disease. The reason for this increase is unknown, but is likely multifactorial. There could be increased susceptibility at the population level due to aging of the population and more people on immunosuppressing medications. Also, there's reason to think there could be more Legionella in water systems with warmer temperatures and aging infrastructure. It's possible that the availability of rapid antigen-based tests is boosting numbers. However, this test has been available since the 1990s. More likely, there's greater awareness among clinicians and public health staff, leading to increased testing and surveillance capacity. Legionella grows best in large, complex building water systems that are not adequately managed. During 2000 to 2014, CDC participated in 27 field investigations for building-associated outbreaks of Legionnaires' disease. In 2016, we analyzed data from these field investigations to see what we could learn about the root cause of these outbreaks. Commander Kunz will talk more about this in his presentation. The upshot of our analysis was that almost all outbreaks were caused by problems preventable with more effective water management, leading to the key prevention message: effective water management programs can reduce the risk of Legionnaires' disease. Water management programs, the heart of Legionnaires' disease primary prevention efforts, are dynamic, continuous processes that identify hazardous conditions within a building or device at increased risk and take steps to minimize the growth and spread of Legionella or other waterborne pathogens. Information about water management programs is available. ASHRAE 188, released in 2015 and revised in 2018, is the first and currently only industry standard for Legionella risk management in building water systems. In 2016, CDC translated ASHRAE 188 into plain language for wider audiences in the form of a water management program toolkit. I'd like to mention two healthcare-specific documents. First, the VHA Directive 1061, released in 2014 by the Veterans Health Administration, which addresses prevention of healthcare-associated Legionnaires' disease, specifically in VHA buildings, and will be discussed by Dr. Gamagay. And then a requirement from the Centers for Medicare and Medicaid Services, released in 2017, which I will discuss next. Water management program regulations in the United States are currently limited to a few jurisdictions by state or local law. Commander Kunz and Tori Burkett will both touch on this topic. While there are other guidance documents currently available or in development, we will focus on these for today's presentation. Due to the high case fatality associated with healthcare-associated Legionnaires' disease, the burden that cases and outbreaks put on the healthcare system, and existence of a prevention framework, CMS issued a requirement for water management programs in hospitals, skilled nursing facilities, and critical access hospitals in 2017. As described in the memo, surveys will review policies, procedures, and reports documenting water management program implementation. As part of the requirement, facilities must conduct a facility risk assessment to identify where Legionella and other waterborne pathogens can grow and spread in the facility water system. Have a water management program consistent with the principles outlined in ASHRAE 188. Specify testing protocols and acceptable ranges for control measures, having plans for what to do when control limits are not maintained, and comply with all federal, state, and local requirements. We have an early look at water management program implementation through data from the National Healthcare Safety Network in 2017. NHSN, which tracks healthcare-associated infections, started including questions about water management program implementation in the annual hospital and nursing home surveys following the release of the CMS requirement. The questions are optional, but the initial response rate was pretty impressive. Across all facility types, more than 3/4 of facilities responded to questions about having a water management program and performing a risk assessment. Of those, the proportion that reported having a water management program, as shown here, ranged from 77% for hospitals to 61% for nursing homes. The survey contained a few additional questions regarding the component of each facility's water management program in an attempt to establish the adequacy of the program. Overall, the responses to these questions indicate that initial uptake appears to be fairly robust, although there is definitely room for improvement. Improving water management program uptake will require multidisciplinary public health input at federal, state, and local levels. Health departments are the cornerstone for communicating with building owners and managers, but not all health departments have experience with water management. As such, capacity building is key. At CDC, providing multidisciplinary technical assistance is our priority. Since 2016, CDC has supported a number of state and local health departments to build Legionnaires' disease response and prevention capacity through a cooperative agreement called ELC. or the epidemiology and laboratory capacity for prevention and control of emerging infectious diseases. Tori Burkett will be talking more about this. In addition to the Water Management Program Toolkit I mentioned earlier, we have developed a whole host of other tools and templates covering epidemiologic, environmental health, and laboratory topics. Commander Kunz will discuss a new environmental health training that was released last year. Our laboratory also provides support through trainings, protocols, and workflow planning assistance. They developed a laboratory preparedness toolkit in 2017. They provide assistance with next-generation sequencing data analysis, pipelines, and protocols. CDC also created the ELITE program, which stands for Environmental Legionella Isolation Techniques Evaluation. This program provides materials to commercial, public health, and academic labs to perform self-evaluation for isolating Legionella from water using culture. While CDC still oversees the ELITE program, the Wisconsin State Laboratory of Hygiene began managing the production and distribution of testing samples, as well as analysis of lab results in 2017. In summary, prevention, a crucial step in reversing this increase in cases of Legionnaires' disease, will require multidisciplinary capacity and a whole lot of coordination between stakeholders. Our next speaker is Commander Kunz from the National Center for Environmental Health.
Good afternoon. CDC and our state and local partners routinely respond to Legionnaires' disease outbreaks associated with the built environment. Through numerous investigations, we have learned that in order to prevent Legionnaires' disease, we must understand the environmental factors that allow Legionella to survive and reach a susceptible host. Working closely with our epidemiology and laboratory colleagues, environmental health provides expert guidance to apply interventions needed to stop outbreaks and prevent future ones. Environmental health response in Legionnaires' disease outbreaks also contributes to evidence-based prevention guidance. Using what we refer to as water management programs, or WMPs, preventing Legionella from growing and spreading in building water systems represents the largest opportunity for reversing the rising trend of Legionnaires' disease. CDC investigations of Legionnaires' disease outbreaks show that 9 in 10 were caused by problems that could have been prevented with more effective water management. For example, a process failure could be a healthcare facility that has a water management program but is missing key elements. We are starting to see this more frequently as healthcare facilities implement water management programs. On the human error side, an example might be a hotel maintenance employee who failed to perform routine checks of the hotel water heater temperatures. This ultimately resulted in missing an equipment failure when the hotel water heater thermostat malfunctioned, causing the water heater to operate in the Legionella growth danger zone. Regarding unmanaged external change, an example could be a brief power outage that causes a cooling tower disinfectant system to malfunction, resulting in the cooling tower operating without disinfection when the power returns. Without a water management program, a process failure, and procedures in place to address external changes, this malfunction can go unnoticed. The vast majority of environmental deficiencies we encounter during outbreak investigations could be prevented with more effective water management programs. If you have worked in Legionnaires' disease, you know all too well that cases and outbreaks can result in expensive litigation. With the ongoing increase in Legionnaires' disease and newly available water management standards, there will likely be an increase in litigation when things go wrong for facilities. However, the proactive implementation of water management programs by building owners and managers could potentially reduce the risk of litigation associated with Legionnaires' disease. In addition, non-traditional Legionella stakeholders, such as insurance companies, risk managers, and trade associations, play a key role by encouraging or requiring the use of water management programs. The bottom line again is that CDC investigations show that almost all outbreaks were caused by problems preventable with more effective water management. At the foundation of water management is ASHRAE Standard 188, titled Legionellosis, Risk Management for Building Water Systems. The CDC toolkit you see on the screen provides an easy-to-understand interpretation of the standard to help building owners and managers evaluate their water system and devices to see if they need a program, and then develop a program if one is needed. Developing a water management program follows a 7-step process. The time it takes to implement a water management program will vary depending on facility size and complexity. The first step is to form a water management program team. This team is largely made up of building staff, but it may be supplemented with outside experts. The water management program team is responsible for making decisions throughout the development of the water management program. Step 2, describe the building water systems and how water is processed and used. Step 3, analyze the water systems for conditions that could support Legionella, such as areas prone to stagnation or temperatures favorable to Legionella growth. In step 4, the team focuses on the process of implementing and monitoring control measures like disinfectant or temperature. Once controls are set and monitoring protocol in place, step 5 determines how to intervene with corrective actions when things go wrong. Step 6 is all about confirming program implementation and effectiveness. We call this verification, or are we doing what we said we would do? And validation, is our program actually working? This is also where the option to sample for Legionella comes into play. The final step, step 7, is maintaining documents and records of the process. This is critical for communicating about the water management program and revising it as needed. But help is available. We understand that developing water management programs can be intimidating, especially for large facilities. Oftentimes, the building water management team just needs to know how and where to start. That is why CDC and partners released a new training on developing water management programs called Prevent LD Training. Prevent LD Training is built on the CDC Legionella Toolkit and directed towards professionals involved in building water management, such as public health, including infection preventionists, building managers, maintenance, and engineering staff, and of course, consultants and suppliers. We encourage you to register for and take Prevent LD training today. Links and instructions are posted on the CDC Public Health Grand Rounds website. So what is the current state of water management program implementation? As Dr. Cooley mentioned, the CMS memo was a significant moment for water management, but it only covers the healthcare side of Legionnaires' disease risk reduction. Additionally, the current laws and policies intended to prevent Legionnaires' disease outside the healthcare environment are minimal. Notably, New York State and New York City passed cooling tower regulations after the 2015 LD outbreak in the South Bronx, which resulted in 138 cases and 16 deaths. Most recently, our neighbors in Vancouver passed a law requiring registration of cooling towers and decorative fountains. While promising, there remains a long road ahead to achieve widespread water management program coverage. Building owners and managers often say that cost and resources can prevent water management programs from getting off the ground because it can be difficult to prioritize or generate resources for these programs when they are perceived as optional. This is in part due to the lack of a requirement or policy for water management programs in the many settings where they are recommended. It will take a diverse set of stakeholders working towards a common goal of risk reduction to truly move the needle on water management use. We need interested stakeholders to carry the message of water management to non-traditional stakeholders such as insurance companies and risk managers. Public health and building owners and managers can lead the way by being champions of water management use within your local communities. Whether risk reduction is motivated by economics or public health, everyone wins in the end when the outcome is preventing Legionnaires' disease. Thank you for your time. Our next speaker is Tori Burkett from the Colorado Department of Public Health and Environment.
Thank you so much for having me here today. In line with many other states and recent national data released by CDC, Colorado has seen a large increase in the number of Legionnaires' disease cases being reported over the last few years. Since 2008, we have seen almost a 700% increase in cases. Even if you only look back to 2016, when we first applied for and received funding from CDC specifically for Legionnaires' disease prevention and response, our case count has doubled. The increase in cases burdens not only health departments, but also the healthcare system and affected communities. In Colorado, more than 90% of people who acquire Legionnaire's disease are hospitalized, and around 10% of them die. The Colorado public health system is considered a decentralized or home rule state. Local health departments investigate the majority of reportable diseases, including Legionnaire's disease, which also typically includes outbreaks and healthcare investigations. In Colorado, there are 64 counties and 55 public health agencies spread among those counties. Our primary role at the State Health Department is to provide guidance and oversight when needed during investigations, which varies heavily across the state depending on each agency's capacity. Since 2016, the number of Legionnaire's disease outbreaks, and healthcare investigations has increased substantially. Prior to 2016, there was an average of 1 investigation per year, but since 2017, we are now typically conducting upwards of 8 to 9 of these investigations annually. The increased case and outbreak burden led to us applying for and receiving funding for Legionnaire's disease prevention and response activities through CDC's Epidemiology and Laboratory Capacity, or ELC, cooperative agreement. Through ELC and gaps identified in our state, we established the need to hold meetings with stakeholders to understand and communicate needs, such as barriers and gaps in awareness or education, facilitate coordination among epidemiology, laboratory, and environmental health staff, implement standard response and prevention protocols such as investigation guidelines, and establish methods for enhanced surveillance and exposure tracking. One of the first tasks we undertook was to conduct stakeholder meetings with various community members to better understand key partners in industries, as well as to create cross-collaborative relationships with industry leaders. Through these collaborations, we better understood major barriers to Legionnaire's disease prevention and response activities and differences across settings such as healthcare facilities, hotels, or recreational water facilities. This helped us establish the types of facilities at increased risk and methods for outreach, taking into consideration existing regulations, burden of disease, population at risk, and the perceived incentive for different groups to participate. Through communicating directly with our community partners, we were also able to tailor our outreach and assistance to meet the needs of each industry or facility type. Another major activity we undertook was to evaluate barriers to uptake of water management programs in a variety of industries across the state. We sought to identify federal and state requirements for different industries or building types, as well as for high-risk sources like cooling towers or recreational water facilities. In Colorado, we found that there were no state requirements for water management programs or Legionella testing, even in buildings at increased risk. And the only federal requirement eventually came from CMS, but only applied to certain types of healthcare facilities. In Colorado, we also have no requirements to register or maintain sources like cooling towers or swamp coolers, unlike some jurisdictions in the Northeast. Additionally, although we do have a code that regulates pools, hot tubs, and hot springs, the regulations are outdated and lack an incentive to adhere. We tried to understand other barriers to water management program implementation through conversations with stakeholders and facilities under Legionella investigation. Through these conversations, we found a few common themes. First, facilities often just didn't know what a water management program was or that they were effective for reducing the risk of pathogens like Legionella. Second, we frequently heard that many facilities either didn't have enough staff or staff with the right skill set to undertake creating and maintaining a program. The third was no surprise, money or the lack thereof. We often heard that there just wasn't enough money to pay staff to dedicate time to creating and implementing a program, hire external consultants, do environmental sampling and testing, or to enact any possible building modifications. Additionally, we found that some facilities lack incentive to create and implement a program, either due to a lack of a regulatory requirement or because they perceive their risk of Legionnaire's disease to be low. We all know that Colorado isn't the only state making effort towards improving Legionnaire's disease prevention and response, so I wanted to briefly highlight some of the great activities and projects that other jurisdictions are undertaking. As many in our audience have heard, and as Commander Kunz mentioned, a large Legionnaire's disease outbreak occurred in the South Bronx in 2015. Following this outbreak, emergency remediation orders, followed by permanent cooling tower regulations in 2016, were implemented by both New York State and New York City to protect the public against Legionella in cooling towers. New York State, for example, requires cooling tower owners to register their towers and report data including inspection dates, bacteriological sample information, Legionella sample information, and seasonal startup and shutdown dates. Data from the New York Department of Health shows that compliance of registered towers has increased from 25% in 2017 to more than 70% today. Following the regulations implemented in New York in 2016, the Philadelphia Department of Public Health launched a unique project titled the Philadelphia Cooling Tower Analysis Project in 2017. This project aimed to use satellite imagery to identify buildings in Philadelphia that have cooling towers, understand current maintenance strategies and their effectiveness for Legionella control, and to serve as a comparison city for New York City to evaluate the effectiveness of cooling tower legislation. Through this project, the Philadelphia Department of Public Health found that in the absence of regulations, not only can satellite imagery be a promising method for identifying cooling towers, it can also be used as a resource during outbreaks to identify possible exposures. They also found that most buildings where cooling towers were identified did not initially have a water management program, and Legionella testing was not typically being done. In 2017, the Georgia Department of Public Health began conducting surveys among tourist accommodations to determine the effect of targeted educational campaigns on water management program use and uptake. When the Georgia Department of Health first contacted facilities, they found that only 9% of them already had some sort of water management program in place. During follow-up surveys, after facilities had been given Legionella and water management program fact sheets and resources, the Georgia Department of Public Health found that the percentage of facilities now having a water management program increased to 28%. Now, although this sounds like a victory and that more facilities were participating in water management activities, it was soon found that from the descriptions of these programs, most of them were not likely to be effective in controlling Legionella. Overall, the data gathered from this project supports the idea that education efforts may facilitate uptake of water management programs. However, the effect of these voluntary changes are likely limited without required implementation. Throughout the work done in Colorado and other jurisdictions across the U.S. to respond to and prevent Legionnaires' disease, we have faced numerous hurdles. Every day, we find out that there is still so much to learn, both within health departments as well as among industry partners and stakeholders. There is a constant flow of new information, which, although exciting, can also be a bit overwhelming. We have to understand and appropriately adhere to regulations, which can vary greatly across jurisdictions at the local, state, and federal level. This can make it difficult to conduct cross-jurisdictional collaborations. For example, there is a strong focus in areas of the Northeast on cooling tower management due to the frequency of their use in that region and the new regulations implemented to control them. However, in Colorado, we don't have those same priorities because cooling towers are less common and even less regulated there. The biggest challenge, though, is that the time and resources needed for Legionnaires' disease prevention and response are substantial. State and local jurisdictions across the U.S. have made great strides over the last few years in understanding the barriers relating to Legionnaires' disease prevention and response, but we can still appreciate the work that we have yet to do. We need to better understand which intervention strategies are working well and which need to be modified. We need to continue to evaluate uptake of water management programs, understanding how new resources and guidelines have helped and what additional resources are needed. We need to evaluate the efficacy of standard policies and regulations to understand if jurisdictional requirements make a difference or if there are additional barriers to adherence. Lastly, we need to maintain communication with community partners to regularly assess concerns and needs and to ensure that we are taking a holistic approach to a unique and challenging public health issue. Thank you for your time and attention. Up next, I would like to introduce Dr. Shantini Gamage.
Well, thank you for this opportunity to talk to you about what the U.S. Department of Veterans Affairs has been doing to prevent Legionnaires' disease in our healthcare buildings. I'll describe why taking steps to prevent Legionnaires' disease is important in the healthcare setting, and we'll then discuss our experiences and lessons learned with implementing our program. Cases of Legionnaires' disease, or LD, can occur from exposure to Legionella in many settings, but healthcare settings have special considerations that make prioritization of LD important. First, when people in a hospital or long-term care facility contract LD, the disease can be especially severe. About 25% of patients who get LD in a healthcare setting die. Second, Legionella can persist in building water systems for long periods of time. If allowed to proliferate, cases can occur. But LD outbreaks from potable water systems look different from other infectious diseases outbreaks. The occurrence of cases may be 1 or 2 a year, or maybe none in a year, and can be considered to be sporadic and unrelated. But if nothing's being done to control Legionella in the water distribution system, then these sporadic cases could be viewed as an uncontrolled creeping outbreak at the facility. In this example of a creeping outbreak, cases of Legionnaires' disease that were definitely associated with the healthcare facility or nosocomial were recognized in 1996. But when a look back was done, it was realized that cases had been occurring sporadically for 10 years. Each of these cases, if recognized as healthcare associated at the time, was an opportunity to take more steps to prevent additional cases. By implementing primary prevention efforts that maintain water systems such that Legionella do not proliferate, healthcare facilities can routinely prevent LD. When understanding risk for LD in the healthcare setting, there are 2 key aspects: occupant-related factors and building-related factors. It's important to know if there are areas of your building that house particularly at-risk patients, such as transplant units or protective environments. Often, though, many areas of a hospital will have patients with some of the risk factors listed in the table on the left. And we also know that people without these risk factors can also contract LD. So in general, it can be difficult to stratify actions based on patient or resident risk. Rather, for many healthcare settings, especially those with overnight stays, such as long-term care facilities or hospitals, aspects about the buildings themselves, such as those listed in the table on the right, can be helpful to inform actions to reduce risk. I'll discuss some of these items later in the talk, noting that all risk criteria will need to be assessed at each facility. So I've described in general some considerations and risks regarding healthcare-associated LD, but let's look at the specific example of the VA policy designed to prevent healthcare-associated Legionnaires' disease in our facilities. The U.S. Department of Veterans Affairs is a federal agency, and the Veterans Health Administration, or VHA, is the branch of the agency that has responsibility for providing healthcare to America's veterans. VHA runs the largest integrated healthcare system in the United States, and we have 170 medical facilities throughout the country and territories. VHA's central office directs implementation of policies at our medical centers for various aspects of healthcare operations, and VHA Directive 1061 is the current policy delineating requirements at our medical facilities for prevention of healthcare-associated, or HCA-LD. The policy is required to be implemented at buildings in our medical campuses where patients, long-term care residents, and visitors stay overnight. The main components of the policy are in alignment with guidelines from public health and standards organizations. Have a committee and a written plan. Have engineering control practices in place to reduce Legionella in building water systems. Verify and validate that the plan is effective, and if it's not, implement corrective actions. A key aspect of the policy is the requirement of a water safety committee at each medical facility. Unlike prevention of other healthcare-associated infections like MRSA, reducing the risk of HCA-LD is not a clinical activity directed at patient care. Preventing HCA-LD is an engineering function. So having a team on site that includes both facilities management and clinical staff is critical for developing, implementing, and assessing an LD prevention program. So it's been almost 5 years since this VHA policy was published. How are things going and what have we learned? I'm going to focus on engineering controls, environmental validation, and clinical validation, and highlight some of our observations. As I've described, we have centralized HCA-LD prevention policy in VHA, but we certainly don't have just one type of healthcare building. These are just a handful of VHA buildings across the country to illustrate how complex and varied healthcare buildings can be. While these buildings may have structural similarities, just like apartments and houses, their plumbing, pipes, and connections can differ. I cannot stress enough how important it is to understand your specific building's water distribution system so that you can tailor general standards and guidelines when writing your specific plans. These are some of the engineering challenges our facilities have had to deal with. The first three challenges may be difficult to address or change, but understanding them is important for decision making. The last arrow bullet highlights things that may be learned by facilities as they try to optimize implementation of control measures throughout their buildings. Optimization may require adjustments for how hot water temperatures are implemented or how biocide residual can be maintained. And it may require assessing water system components such as on-site large water storage tanks and how that affects biocide levels at the tap. These are real-world issues that may not be obvious when first drafting a prevention plan. The way we validate that HCALD prevention plans are working in the VA is to do surveillance. Clinical surveillance for cases of HCALD and environmental surveillance for Legionella and water distribution systems. Each can indicate that implementation of controls to reduce Legionella risk may need to be adjusted. Let's look at each surveillance system a little closer. Clinically, the VA is doing a lot to understand rates of LD, and our data suggests that our system is improving. When we looked at all the LD cases reported in our centralized surveillance system from 2014 to 2016, we saw that the rate of LD with overnight VA exposure decreased significantly, and that's the green arrow on the slide. This is in contrast to an increase in the overall rate of LD, the first blue arrow, which was largely due to an increase of LD caused by cases with no VA exposure or community-associated cases. That's the second blue arrow. So in summary, while we see the same overall increase in LD cases that Dr. Cooley mentioned in the US in general, the LD rate for cases associated with our healthcare system went down. So what have we learned about LD case diagnosis, the cornerstone of the surveillance system? We encourage several practices in VHA to optimize detection of HCA-LD cases. Suspect LD in patients with pneumonia and order the diagnostic test as appropriate. This is especially important when a case potentially could have occurred from exposure at the healthcare facility. And when a case of HCA-LD is identified, especially if it's definitely associated with the facility, we recommend that the case be documented so that the facility water safety team is knowledgeable about the case for future assessments of risk with the building. VA policy requires clinicians to be notified when environmental data suggests that there's a heightened risk for LD, and cases of HCA-LD trigger actions to prevent further cases. The second way that we validate the effectiveness of engineering controls in reducing risk is by requiring all buildings under the purview of the directive to undergo quarterly water testing for Legionella. This slide of our environmental Legionella data show that, as a national system, VHA is reducing Legionella positivity in our building water systems. So what have we learned about implementing routine environmental testing for Legionella? There's little guidance or consensus available in the US for whether routine testing of potable water systems for Legionella should be done. If a decision is made to do it, include testing criteria in your written plans or procedures. Most importantly, have a plan for what you will do with the results. For validation of engineering controls, a key aspect of assessing Legionella results is to determine what they are telling you about how in control your system is. For example, if the extent of positive samples keeps increasing each testing cycle, that could indicate that Legionella are proliferating in the water system. Also important is determining if the results indicate if remediation of the system is necessary to reduce risk to building occupants. Ultimately, it comes down to managing and using the data being collected to inform decision-making. Which brings us to some additional sets of challenges and lessons I'll discuss. Categories of questions to consider when implementing policy. Data analysis and trending. Are the data that are collected being used to understand how things are going? Is anyone routinely looking at the data? And do the trends indicate that changes need to be made in the implementation of engineering controls? Knowledge base. How well do people on the water safety team understand aspects of Legionella control and surveillance? Are contracted consultants knowledgeable, and how would you assess that? Are clinicians, especially new fellows and residents, aware of the importance of LD diagnostic testing for validating the program and preventing additional cases? Verification and documentation. Is the program being assessed periodically to ensure that practices are being implemented as expected? Who will do that? Are decisions and requirements documented so that staff are aware of facility policy? And resources, or sufficient staff and funding available. So in summary, healthcare facilities are considered high-risk settings for LD. HCA-LD may not happen at every healthcare building, but recognize that it can happen at any healthcare building. Take steps to prevent cases. And when an HCA-LD case is recognized, realize that other cases could happen. Primary prevention in the long term are needed to prevent a creeping outbreak from occurring and potentially leading to many cases. Know your building water systems and associated risks. Implementation of policy will require more than just having a written plan. It will require ongoing assessments and management, teamwork to bring together experts from engineering and infection prevention and control, and habitual optimization of efforts based on observations. But I hope, as I've demonstrated from the VA experience, that system improvement is possible to reduce the risk of Legionella infection in the healthcare setting. Thank you.
We do, and I want to remind our online viewers to go ahead and send their questions to grandrounds@cdc.gov, and we'll get in as many as we can. A question from Celine. The first presentation on water management in reference to exposure included the phrase, water going down the wrong pipe. Can you clarify whether the word pipe refers to a possible route of aspiration in a patient or to a mechanical pathway in the water management system?
Microphone?
Yeah, hi, I'm Marcus Plush. I'm the Chief Medical Officer for ASTA, which is the Association of State and Territorial Health Officials. And I had a question. I think two of the speakers mentioned one of the early outbreaks of Legionella in the South Bronx. The response to that was some really thoughtful regulations from New York State about how to prevent these things from happening in other circumstances. Unfortunately, since then, we've had a couple of states where the response has been criticism of how the state health department dealt with the situation, and even more unfortunately, litigation, manslaughter charges against some of the leadership in the health departments. And so we're concerned about that. I realize this is a difficult question, and some of this is the state of our society right now, but I did wonder if any of the speakers have any ideas about how we can shift back to the response to some of these kind of tragic outbreaks really being about looking at the root causes as opposed to looking at how the outbreaks are investigated.
Sure, I'll take the first pass at that, and then maybe Jason or others could. Yeah, this is tough. And, we work with, all the state and a lot of the local health departments. And by and large, everyone is just trying to do the right thing and prevent additional cases of disease, minimize the impact of any Legionella in the environment. And so I think that from our experience, there is always the effort, first and foremost, to reduce the risk to anybody who might be at risk at that time. So it might be different from setting to setting. So in a healthcare facility, different people might be at risk than in a community outbreak where cooling towers might be implicated. And so I think there now also is a need to kind of translate what's already happening, good work to protect other individuals from getting Legionnaire's disease, and really translate that into early and appropriate risk communication. And I think we're kind of in the early stages of that. We realize how important it is. And we want to be sure that the right audiences get the right messages so they can reduce their own risk. And I think there's as you mentioned, there are some outbreaks that have kind of occurred in the public spotlight. And I think there are lessons learned very publicly. And so I think we're all working towards A, making sure that, everyone is protected, and B, that the right people who need to know do know important information to protect their health. Does anyone else have anything they want to add to that? All right. Next question. Susan, anything else online? Yes.
Next question from Michael. What should a homeowner do to prevent Legionella bacteria in a hot tub?
Yeah, that's a good question. So personal hot tubs, the risk factors are the same as like public hot tubs. There are some design characteristics associated with personal hot tubs that make them a little bit more different than public hot tubs. However, maintaining adequate disinfection levels in that hot tub, ensuring that the filters are being maintained appropriately, draining and scrubbing that hot tub routinely, and then just following general maintenance procedures that are outlined by the manufacturer.
Yeah, yes, good afternoon, and thank you for your presentations. My name is Max Zarate Bermudez, and I'm a colleague of Jason working in the same branch. My question is related to the water management plans. It seems like at least a couple of you talk about it, and might be one way to address the Legionnaires issue. How much would it cost to implement a water management plan? I know there are different types of systems, different sizes, so the cost probably varies. And the second question is to Dr. Gamache. It seems like the VA is introducing the regular monitoring of Legionella, or suggesting it. And if you have knowledge about the cost too.
Cost is a difficult thing to assess, especially for this type of program, because you're correct. It is it can be very specific to each facility. We have a saying, if you've seen one VA, you've seen one VA. And that's because we have different campus styles, large campuses spread out, or tall buildings, and the management program in each type could be different. So it's hard to pinpoint. And the other aspect is whether there's Legionella in the water or not, and how much they need to remediate, whether they've had healthcare-associated Legionnaires' disease cases in the past, and so efforts for prevention may need to be a little bit more rigorous. So putting a cost on that is difficult. And the other aspect is, we're a healthcare system that wants to prevent disease. And so that's the priority for us, is preventing the cases. As for testing water for Legionella, that was your second question, right? We've decided in the VA, and I have to stress that we're not a public health agency, we're a healthcare organization, and this is just how our healthcare system has decided to approach the water management program. And so, there's probably information you can take from it. I encourage you to look at our policy, which is publicly available, and see if it fits for what you want to do. We chose to do both clinical and environmental surveillance to really have a good handle at facilities on how our engineering controls are working. And that, that's an option that different people can choose to do.
I'll add on to your first question. So like Dr. Gamage said, it's really difficult to assign a cost. And like she mentioned, there are a lot of factors that play into that. One other thing to consider is population at risk, the requirements in your state or local jurisdiction. Some places have very strict requirements for things that you have to do. You have to test. Some places have no testing requirement. So that can be a pretty big expense as well. One other thing that we've also seen is that the capacity of each individual facility to create their program varies a lot. You have some facilities that would be capable of creating a program and implementing that program entirely internally. So they may have staff that are able to do that. Others may have to hire a consultant, which can obviously increase the cost of putting that plan together if you're hiring people to help. So there's a lot of factors that play into that cost, and I think it depends a lot on the risk, the type of facility, the regulations that are in place, and the capacity of that facility.
Susan, another question online.
We have a lot of questions online. Thank you. From Thomas in Maine, what is the CDC position on how much Legionella bacterium is considered high risk?
CDC's position on Legionella in the water, I mean, we approach it from the public health perspective, and for us, no known level of safe Legionella has been identified. Usually, we are approaching this from the perspective where there's been a case of disease, in which case any Legionella is important. But even from the prevention standpoint, we have seen outbreaks associated with very, very low levels of Legionella. So any Legionella to us means that there needs to be some kind of interrogation of the system to see what's going on and see if something needs to be updated, modified. It doesn't mean freak out and stop everything, but it does mean that something might need some attention. Did you want to add to that, Jason? No. Okay. All right. Yes, another one.
From Sharon at Port Huron Hospital, what do you recommend be done after water shutdowns in healthcare facilities?
So I'll start off this. So there are, I guess when you refer to water shutdowns, it could be like water interruptions or disruptions to water. That could be following a natural disaster. There is guidance available on CDC's website for returning healthcare facilities to operation following water disruptions. And I don't have that link offhand, but that does exist there. Obviously, one should be on concern for pathogens beyond Legionella when dealing with water disruptions. I don't know if the VA has a perspective on that.
What I would say, I would add to that, and I would defer to CDC's in general guidance, because there is a whole lot more involved than just Legionella prevention. But for the purpose of this talk, and Legionella prevention, what I would say is this is why you have a team, and they are supposed to meet regularly. In our directive, it's at least quarterly and ad hoc as things arise. And so, recognize that, first of all, would you know that has happened? And that's something that may or may not happen. But if you realize that there is a disruption of some sort, get your team together and see if you need to assess, the engineering controls, if they've affected biocide levels, things like that, that could affect the growth of Legionella in your system.
Dr. Benowitz.
Hi, Isaac Benowitz. I'm currently in the Division of Healthcare Quality Promotion, but my question is actually not about healthcare settings. I wanted to follow up on some of the comments that Tori Burkett from Colorado made about sources of Legionella. So I think you mentioned that Colorado has taken a different approach than some of the jurisdictions in the Northeast, and that part of the rationale behind that was that you don't see cooling towers in use in as many buildings, and that the sources of Legionella outbreaks are elsewhere. You mentioned that you're investigating like 8 to 10 outbreaks per year, so I was wondering if you could comment on what other sources you're seeing and what else we should be thinking about other than cooling towers.
Sure. So we see a lot of outbreaks in Colorado associated with recreational water sources. Typically, that's in something like a hotel, so a hotel pool or hot tub. We see those fairly frequently. We've also investigated not necessarily healthcare facilities, but assisted living, independent living facilities that also have those types of sources, so have pools in them. We also have a source in Colorado called a swamp cooler, which is similar to a cooling tower, but on a much smaller scale. They work a little bit differently. So we've also seen investigations where we have seen that as a source. The reason why we differentiate that from a cooling tower is because it doesn't have nearly the same spread as a cooling tower, the ability to expose a larger group of people. We also investigate healthcare associated infections. So if we have one case that is definitely or very likely associated with a healthcare facility, we'll investigate those. And we found Legionella in places like decorative water fountains, and then in potable water systems. So, yeah.
Yes. One more question.
Tyler from Texas. Most of these facilities that are not healthcare facilities struggle with the financial constraints associated with routine environmental sampling. Thoughts on enhancing this process for institutions reluctant to pay for it?
That's a great question. I think it really also depends on the size of the facility and the complexity of the water system. And so, what might work for a very small hotel or small nursing home that has one loop might be very different. And maybe simple flushing and Legionella testing, if at all, could be done fairly infrequently to be sure that the water management program is working as intended. Whereas other facilities, hospitals, places that have protected populations, transplant units, and that kind of thing, may be more in need of fairly frequent validation that their program is working. Do you have other thoughts about that?
No, I would direct these facilities to our training, Prevent LD. I think that'll allow them to take some of the very first steps to developing a water management program. And oftentimes what we see in our outbreak investigations are, 9 out of 10 deficiencies that we see are preventable with water management programs. So it's taking those first steps to identify what the risk is associated in your facility and moving forward with that water management program. We would encourage facilities to begin to develop these water management programs.
All right. Thank you all very much. For those of you online, you will get answers to your questions. Let's have another round of applause for our outstanding speakers. And please join us next month for CDC Public Health Grand Rounds. Thank you.